Hello, I am Dr. Indu Khosla. I am a pediatric pulmonologist and an international sleep expert here at the SRCC Children's Hospital at Mumbai. Today I am going to touch upon a topic which goes under-recognized and under-serviced, and it has long-term implications if not diagnosed on time or treated on time. I am going to talk about sleep apnea in children. You will wonder, or you would think that this probably is a problem only of the adults. Unfortunately, children also have a high incidence of sleep apnea. So what is sleep apnea, or commonly called as OSA or obstructive sleep apnea? Obstructive sleep apnea is a cessation of breathing or stopping of breathing or shallowing of breathing during sleep, which results in drop in oxygen and increase in carbon dioxide in the children's blood when they are sleeping. Obviously, we need oxygen. Oxygen is required for our existence, for us to grow, for our body to be well nourished, and for every bit of energy that is produced in the body. So if the child who spends more than, I would say, 40-50% of his time of his life sleeping, if he doesn't get enough oxygen during sleep because of an obstructive sleep apnea, obviously this is going to have long-term implications. So what are the symptoms and signs of sleep apnea, and how common is it? So it is said that 3 to 15% of children who snore may have a sleep apnea. Yes, you may have a child who normally snores, and that's called primary snoring, and that has no long-term consequences. But if you are snoring and you are dropping oxygen during sleep because of the obstruction of the airway, then that is sleep apnea. What are the symptoms and signs, and when should the parent be worried? So if you have a child who during sleep takes odd postures, or who makes funny noises during sleep, snores, snorts, gasps, gets up during sleep as though he's searching for a breath, or this child in the day is either excessively hyperactive or very sleepy, complains of headaches. Sometimes these children also bedwet in night, because when they get a sleep apnea episode, the sleep gets disturbed and they can start bedwetting. So in nighttime symptoms and daytime symptoms, you will think of sleep apnea. So these children who have prolonged sleep apnea may have problem in memory, in learning new functions. They may drop in their school grades, and if it continues into adulthood, they develop metabolic syndrome. When I say metabolic syndrome, they tend to develop high blood pressure, they are prone to getting diabetes, and they can have poor health not only on their lungs, but also it has an impact on the heart as well as the brain. So acutely, a child may be irritable in the day because he has not slept well in the night. He may complain of headache, and he may not feel fully rested, and this is because these are all symptoms and signs of obstructive sleep apnea. To whom does it occur? Children commonly who have enlarged tonsils and adenoids may be predisposed to developing sleep apnea. The other big chunk of children whom we see with sleep apnea are children with obesity, and this is a problem that we have moved from malnutrition to malnutrition, and we are seeing a number of children who are obese. So children who are obese have a very high risk of sleep apnea. Then you have complex sleep apneas, and these are children who have some muscular problem, whose muscles are weak, children who have skeletal problems, whose spine is not straight, or who have other problems in the face, where the face looks abnormal, the shape of the face, the shape of the oral cavity, which are called craniofacial syndromes in our language. And not to forget children with certain syndromes like Down syndrome, which is very, very common. These are kids who are prone to sleep apnea. We have certain other syndromes like Prader-Willi, which are syndromes which have associated obesity. So Prader-Willi syndrome. Now these are kids who are again predisposed to sleep apnea. You may have seen those small dwarfs in a circus, these are people who have achondroplasia. Now they are also predisposed to sleep apnea. Children who have jaws which are small, the jaw which goes behind, and syndromes like Pierre-Robin's, they also are predisposed to sleep apnea. So it's a big basket, but majority is tonsils, adenoids, and obesity. So how do you diagnose sleep apnea, and how do you treat these children? First and foremost, a very important is the history of the parents. How is the child during sleep and during their daytime? Then a thorough examination to see if the child has enlarged tonsils, adenoids, history of snoring, etc. All that is very, very important. But the gold standard test to pick up sleep apnea when we suspect it based on the history and the clinical exam is to do something called a sleep study or polysomnography. So for that the child has to be in hospital for the night. We connect certain wires through the child's body. It doesn't prick the child. We have to prepare the child for it. It records the child's sleep stages. It records the child's oxygen through the night, the carbon dioxide through the night, and we also video record the child through the night, and it tells us whether the child has a dip in oxygen, whether the child has obstruction in his airways, because we put two belts on the chest as well as the abdomen to look for movements if the child is obstructed in the breathing at night. So whether the child is having an apnea or a shallow breathing at night. So it's an overnight study which helps us diagnose sleep apnea. So once you diagnose sleep apnea, you would also need to know what is the cause of the sleep apnea. If the problem is as simple as tonsils and adenoids, yes, it's easy. We get the tonsils and adenoids removed and the child would be, probably in most of the kids, the child would be much better. But of course, we need to follow up these kids to see that the sleep apnea has completely disappeared. If it's an obese child, then we have to look at lifestyle changes, weight loss, exercise, the regular things that we would do for obesity. If it's a syndromic child, that is if a child who has some abnormality in the face, the skull bones, the jaw, then we need to work along with our plastic surgery and dental teams to look for procedures like the rapid maxillary expansion or mandibular extension, etc., to make us place in the oral cavity. And we also need to work with dentists with this and the plastic surgeons to get us the correct solution for these problems. Children who have syndromes like Down syndrome or other syndromes like achondroplasias or Prader-Willi, etc., these are kids, if they have enlarged tonsils and adenoids, that's the first thing we target and we get the tonsils and adenoids out. But if these are kids who they have complex OSA, so they may require the support of something called a CPAP or BiPAP at night. So if these are kids whom we do a titration study on a sleep in a sleep lab, and then we have to put them on devices which they have to sleep with that device through the night. The device gives them pressure, so to keep their airways open when they sleep in the night, and that delivers them adequate oxygen and keeps their sleep apnea away. So this is how we would treat. So either just simple and there is something in mild sleep apnea, we would also do medical management, use of nasal sprays and certain oral medications. So that is only for mild sleep apnea. Otherwise, either we need a surgical management or we fall back on CPAP for those children who have complex OSA. So dear friends, it's very important that you pick up if your child has an obstructive sleep apnea, if he's having difficulty in sleeping at night, getting up frequently, odd postures, making noises, and does not feel rested in the morning when he gets up, and he has a headache, or he's not doing good in school, or you're getting a complaint from the teacher that he's excessively sleeping or he's hyperactive. Think of obstructive sleep apnea as one of the causes. Please go to your doctor and identify the problem and get it rectified. Because if it goes undiagnosed, it has long-term complications. It has acute complications, but it has long-term complications which are irreversible.